There are three main types of calcium channel blocker. Some calcium channel blockers act on calcium channels found in vascular smooth muscle, and others act on calcium channels found in the heart. The first group we'll start with are dihydropyridines, and these are the class of calcium channel blockers that include amlodipine, nifedipine, nimodipine, basically any that end in pine, and these are highly specific to vascular smooth muscle. So let's quickly review how they work. Now, normally in a vascular smooth muscle cell, the propagation of an action potential down the sarcolemma or the cell membrane triggers the opening of voltage-gated calcium ion channels, which causes an influx of calcium into the cell and a gradual rise in intracellular calcium concentrations. It is not entirely important to understand the pathway that leads to muscle cell contraction, but essentially when intracellular calcium concentrations increase, this causes the muscle cell to contract, helping to keep the blood vessel constricted. Now, if someone is given a calcium channel blocker, particularly a dihydropyridine, which are specific to vascular smooth muscle, this decreases the intracellular calcium ion concentration, leading to smooth muscle cell relaxation. And as you can see, this causes vasodilatation of the blood vessel. Vasodilatation of arteries leads to a reduction in arterial blood pressure, and this is why calcium channel blockers are used to manage hypertension. Now, as well as dilating systemic arteries, calcium channel blockers can also dilate coronary arteries. In patients with angina, there is typically an atherosclerotic plaque plus or minus a thrombus that reduces blood flow distal to the lesion. Patients experience angina when the coronary artery undergoes vasospasm around the thrombus or the plaque, leading to reduced coronary blood flow and myocardial ischemia. Certain calcium channel blockers help to dilate the artery and partly restore coronary blood flow. This is what resolves the ischemic chest pain. So that's one way in which calcium channel blockers can be used for prophylaxis for angina by dilating coronary arteries, but they can also dilate systemic arteries. Systemic arterial vasodilatation and reduction in systemic vascular resistance reduces afterload and therefore the work required of the left ventricle. This reduces the myocardial oxygen demand of the heart, meaning the myocardium is less likely to become ischemic. At this point, it's useful to point out some of the side effects of calcium channel blockers, particularly the dihydropyridines. Vasodilatation of systemic arteries includes cerebral arteries. When these vessels expand, it can cause a slight increase in intracranial pressure, and patients may experience a throbbing headache. Throbbing thought to be due to the pulsation of the meningeal arteries. As with any drug that lowers blood pressure, there is also a risk of severe and potentially symptomatic hypotension that may cause dizziness, syncope, or falls, particularly in older patients who have a reduced baroreceptor response. On the topic of the baroreceptor response, one important thing to mention is that short-acting, potent calcium channel blockers which cause vasodilatation can sometimes cause a significant hypotension that results in a reflex tachycardia. When arterial blood pressure drops, the physiological response is to increase heart rate in order to maintain cardiac output. This is mediated by the baroreceptor reflex, where baroreceptors present in the aortic arch and the carotid bodies detect a drop in blood pressure, such as that which occurs when you stand up from sitting, and they send signals to a part of the brain that increases sympathetic activation, resulting in a reflex tachycardia, increased heart contractility, and vasoconstriction. Patients with ischemic heart disease experience chest pain on exertion because their heart rate and contractility increases to a point where the coronary arteries that supply the myocardium cannot deliver sufficient oxygen to the tissue. So short-acting, potent calcium channel blockers, which cause potent vasodilatation and a resultant reflex tachycardia, can be harmful as they may exacerbate angina in patients with ischemic heart disease. Therefore, for patients with high blood pressure, slow-acting forms of calcium channel blockers are often given to prevent the occurrence of this reflex tachycardia, so they can be given to patients with concomitant ischemic heart disease. The next type of calcium channel blocker is Verapamil, and whilst Verapamil also has some small effects on vascular smooth muscle calcium channels, it mainly inhibits calcium ion channels present in the heart. Cardiac myocytes are the main cells involved in contraction in the myocardium, and like smooth muscle cells, they contract in response to changes in intracellular calcium concentrations. So, when an action potential is sent down the sarcolemma of a cardiac myocyte, it causes the opening of voltage-gated calcium ion channels, which allow an influx of calcium into the cell and a sharp rise in intracellular calcium concentrations. This enables the cardiac myocyte to contract. Now, if someone is given a calcium channel blocker like Verapamil, which is specific to cardiac calcium channels, this decreases the intracellular calcium ion concentration, leading to reduced contraction of the cardiac muscle cell. Reduced contractility of the heart is referred to as negative inotropy, and this is why verapamil acts as a negative inotrope. Verapamil is not only specific to calcium channels present in the cardiac myocyte, but also acts on calcium channels in the pacemaker cells, particularly at the sinoatrial node and the atrioventricular node. The sinoatrial node determines the rate of the heart. So normally these pacemaker cells in the heart generate action potentials, firstly using sodium and T-type calcium channels to cause a slow depolarization, followed by the opening of L-type calcium channels, which cause a more rapid depolarization, and hyperpolarization, which triggers the propagation of the action potential. Potassium outflux then causes repolarization. Now, if someone with a tachycardia takes verapamil, this blocks some of their L-type calcium channels, meaning it takes slightly longer to generate an action potential, this slowing the heart rate. So, by slowing action potential conduction at the sinoatrial node, this reduces heart rate, also known as negative chronotropy. And this is why you may have heard of the term rate-limiting calcium channel blockers, of which verapamil is one. At the atrioventricular node, and further down the conduction pathway, calcium channel blockers can reduce the velocity at which the action potentials travel, and this reduction in conduction velocity is referred to as negative dromotropy. These two actions of verapamil in causing negative chronotropy and negative dromotropy explain why it is used to treat certain cardiac arrhythmias, for example supraventricular tachycardia. It is important to note that in patients with slowed conduction velocity, for example in patients with heart block, rate-limiting calcium channel blockers are absolutely contraindicated as they may cause complete heart block. So that pretty much covers the cardiac effects of calcium channel blockers, particularly verapamil, which is specific to those channels. Finally, we have a drug called Diltiazem, and that sort of lies in between both dihydropyridines and verapamil, in that it's half specific to vascular smooth muscle cells and half specific to cardiac calcium channels. This means that so diltiazem can cause a certain level of hypotension, so it can reduce blood pressure. However, it can also reduce heart rate as well. So that's good for patients with angina because it prevents that reflex tachycardia that was discussed earlier.